Welcome. Hello, everyone, and welcome to today's webinar, Understanding the Value of Guideline-Based Practice for Preventing Pressure Injuries. My name is Anne Ornelas, and I'm the Associate Marketing Manager at Mölnlycke Healthcare Canada. I'm pleased to introduce our guest speaker, Dr. William Padula, who is an international thought leader in health economics and outcomes research, with 2 decades of experience in the academic, pharmaceutical, and medical device sectors. Dr. Padula earned a PhD in pharmacoeconomics from the University of Colorado and completed his training in health economics at the University of Chicago. He's a professor of pharmaceutical and health economics at the University of Southern California and is a fellow at Schaeffer Center for Health Policy and Economics in Los Angeles. Before joining the University of Southern California and consulting for life science industry, Dr. Padula was a professor at Johns Hopkins Bloomberg School of Public Health. Dr. Padula is also the principal and co-founder at Stage Analytics. His work focuses on theoretical foundations of medical cost effectiveness analysis and its connectivity with data science. He has more than 100 scientific publications with innovative finds about surgical outcomes, including a vast contribution to the literature on the economics and comparative effectiveness related to pressure injury prevention. Please submit your questions by typing them into the Q&A box of the control panel. You may submit your questions at any time. We will collect them and address them during the Q&A portion at the end. Welcome, Dr. Padula.
All right, thank you for the nice introduction. It's a pleasure to be here today with Wounds Canada. Normally, in my capacity with the National Pressure Injury Advisory Panel in the United States, I'm focused on presenting this type of information to people down under Canada in the States, but it's a pleasure to come up north and reach out to you all. And there's been a nicely established partnership, I think, between the NPIAP and the Canadian Pressure Injury Advisory Panel that allows us to do more together. So hopefully what I share with you today, thinking about value in pressure injury prevention based on the guideline, changes the way that you think and helps Canada, Wounds Canada, and the CPIAP work together in advancing access to better pressure injury prevention across the country. So with that said, we'll get started. Noting a couple of disclaimers, these are my funding opportunities and collaborations with commercial companies. And also, just to clarify, I'm not a clinician, I'm an economist. And so hopefully I teach you something new. There will not be a quiz at the end of this session on economics. So just sit back and relax and know that it's more information to guide your practice. But I also am not able to necessarily answer questions about how do I reposition a patient or how do I deal with a 3-inch wound that I need to debride. We can keep it focused on how do you engage leadership and how do I afford to pay for preventive practices or for effective treatment of pressure injuries. I can definitely be helpful there as it relates to the presentation. Our objectives today are threefold. I'll help you interpret real-world evidence to support technology assessment of pressure injury prevention technologies such as dressings, and you'll see repositioning systems in there as well. We'll be able to interpret some of the economic data on pressure injury prevention, and then finally understand what the overlap is between the international guideline and current technologies to improve pressure injury prevention. So I think this is going to be fairly cutting edge for you and teach you something new, like I said. But let's start with who we are, the faces in the room. This unfortunate tale of 2 nations, not having to do with any elections right now, but really what the numbers are for pressure injuries with respect to some other important health outcomes that we consistently look at and measure improvement in public health by. When you look at HIV and AIDS in the United States and Canada, they're concerningly high numbers, but I would say over the last 2 to 3 decades, we've gotten this under control. In the US, for instance, 4,900 people or more die of HIV/AIDS every year, and in Canada, this is 133 individuals. Opioids have obviously taken us by storm in a very serious negative way since the use of overprescribing of OxyContin and so forth, and heroin use. We see over 80,000 deaths in the United States, over 3,900 deaths in Canada. Automobile accidents continue to burden both of our societies, 42,000 deaths by automobile in the US and over 1,700 in Canada. Also keeping in mind the US is 10 times the size of approximately in terms of population that Canada is, so that explains some of the discrepancy in these numbers. And then look at pressure injury. Pressure injury in the US, over 60,000 deaths a year is what the NPIP markets. And in the Canadian provinces, based on some calculations that I've done, there are over 1,400 deaths a year just from pressure injury. And so these conditions, of course, HIV/AIDS, opioid epidemic, automobile accidents, those are concerning that we talk about every day. But look at the numbers from pressure injury. If we're talking about pressure injury, it's right up there with opioid deaths and automobile accidents. And yet we continue to focus on other things besides pressure injury prevention. And I think by putting pressure injuries in the spotlight, we can do more to accept the failure of health systems to deliver adequate preventive care to the patients. Notice I didn't say failure of the clinician. I said failure of the system, as I'll get to, and do more to invest in an infrastructure to improve prevention of pressure injuries over the long run. So let's dig into this a little bit more. Of course, the burden of pressure injuries, just based on these numbers, is remarkable. You see in Canada, 20,000 patients develop a pressure injury every year. That's a national incidence rate of plus or minus 1%. You have economics of pressure injuries in the United States, looking in Canada, over 900 million a year in Canada alone. That's $2.4 million spent a day, $20,000 per patient. And it's approximately 19% of all patient safety incident reports. And liken that to similar problems in the US, where 2.5 million patients develop a pressure injury every year. That's a national incidence rate of over 2%. And it's costing the US healthcare system $27 billion a year. That's $75,000 to $150,000 per patient. The settlements in the legal system related to pressure injuries in health systems is remarkable, where most health systems are paying out $250,000 or more per settlement, and it's the second most common billing claim in hospital records. So clearly, there's a lot that we could do to improve health outcomes by preventing pressure injuries, and in turn save money on a costly preventable condition that could be put into a lot of other issues. And as an economist, I always think of opportunity cost, or the cost of the next best alternative. Imagine what Canada could do with $900 million if it didn't have to spend it on preventable pressure injuries. You could afford the latest groundbreaking drug to treat cancer or to cure sickle cell disease. That the debate over whether we could afford these other costly medicines for rare diseases and severe diseases wouldn't be an issue if we got rid of the cost of these types of conditions. And so let's learn a little bit more systematically how to improve our investment in pressure injury prevention and hopefully create financial bandwidth to address other health system issues as well. Starting here with pressure injuries, I think I'm preaching to the choir here. You all know what they are: underlying skin and tissue damage caused by pressure, friction, and shear over a bony prominence. Most often, your patients with higher acuity, older age, or those who are malnourished. Of course, they're costly to hospitals, and you could call them what you want. We changed the terminology through NPIP in the last decade, but many people still refer to them as decubiti, as pressure ulcers, but we're all talking about the same thing. And the simple pressure injury prevention checklist, it is simple, right? To risk assess with the Braden scale, for instance, upon admission, reposition patients side to side every 2 to 4 hours, manage nutritional matters improve the use of modern support surfaces like better mattresses or mattress overlays, manage moisture and incontinence issues, and perform continual nursing education about what's in the newest version of the guideline. And the last version of the guideline came out in 2019. It's a nice thick 350-page booklet co-published by the NPIAP, the European Pressure Ulcer Advisory Panel, and the Pan-Pacific Pressure Injury Advisory Panel. So it's a little bit tongue-in-cheek when I say it's simple, right? We know it's not actually simple, that there's a lot that has to be done just to do a simple risk assessment as it is on this checklist, or that repositioning a 450-pound patient from side to side is not a small matter, no pun intended. So we have a lot to unpack here in these individual steps, and these are costly, time-consuming. The good news is technology is constantly advancing, and technology can either assist or replace a lot of these steps in the prevention guideline. The question is this technology affordable? Is it cost effective? Does it improve outcomes? And so that's what I'll be digging into you with the evidence that I have available as of today. Let's start all on some fundamental principles with respect to this guideline. Where does this guideline fall into the healthcare delivery system? I think there's no better framework to refer us to than the Donabedian model. And many of you may have heard of this framework before. It's common in nursing practice to refer to the Donabedian model. It's the fundamental underlying framework of the magnet model for nursing quality. Donabedian, Avitas Donabedian, was considered the father of quality improvement in public health, and he came up with this model: structure, process, outcomes. Introducing good structure to delivering healthcare is one thing, and that could be considered a checklist. That could be considered a guideline, like the pressure injury prevention guideline. But achieving better outcomes in terms of pressure injury prevention or improved wound healing depends on the process by which structure is delivered. And so obviously having a 350-page book tells you everything you need to know about the structure, but implementing the components of that guideline are very complex, the way that it's introduced. And the challenge that I've always been presented with is, how do we take a complex 350-page guideline and boil it down in its two key core components so that the process becomes simpler to implement, and therefore pressure injury prevention is a easier task to accomplish to achieve better outcomes. And then on top of that, think about this figure that was developed by a famous medical author, creditor for the Annals of Internal Medicine in the early 90s. You know, pressure injury prevention obviously is not the only thing that nurses especially have to worry about. When you take an elderly hospital who's admitted, or an elderly patient who is admitted to a hospital, every one of these boxes represents a separate guideline: managing oxygen levels, preventing falls, improving the likelihood that a patient who, let's say, is catheterized doesn't develop a UTI, keeping a patient who's on a respirator from aspirating and getting a lung infection, and obviously having a serious negative outcome that way. That all of these boxes for one patient represent a separate guideline. So pressure injury prevention is not conducted in a vacuum. It's conducted with respect to many other evidence-based tasks that need to be accomplished. And what I've seen our field do time and time again is successfully try to simplify the process by which structure is implemented to achieve better outcomes, leading back to that Donabedian approach. We've seen Atul Gawande and colleagues introduce the surgical safety checklist to try and reduce surgical site infection. We've seen Peter Pronovost and colleagues at Hopkins introduce the CLABSI prevention checklist to reduce bloodstream infections. Michigan, for instance, introduced this CAUTI checklist on timing to remove the catheter and limit the likelihood of a urinary tract infection. But what I like to say is, now we're at the point where, okay, we've simplified structure from thick guideline books down to checklists that are easier to implement. So it makes the process of achieving pressure, or in this case, infection prevention more likely. But as the text here says, it's a proverbial logjam for clinicians to be able to implement all of these checklists at once on every single patient every single day to keep them safe from harm. And you can imagine like a patient who's undergone surgery, and for their surgery, they were catheterized and they had a central line and they were laying in one place for 6 hours. All these things do need to be done on a daily basis. And we haven't even caught up in terms of pressure injury prevention, where surgeons introduce the surgical safety checklist, or where intensivists introduce the CLABSI prevention checklist. So we need to catch up, and we also need to find a way to assert pressure injury prevention into the realm of all of these other structural components in patient safety. So this is where a first learning lesson for you is that there was a framework that was introduced a while back now by two Canadian researchers, as a matter of fact, Gluberman and Zimmerman. They introduced this, what they call simple, complicated, complex framework. And you can look at health system delivery of these preventive tasks as complex from multiple dimensions. It's complex because there are many things that need to be achieved, like the creditor figure implies. And it's complex because pressure injury prevention, the guideline isn't easy to follow. It's very thick and complex. And the tasks to accommodate the patient for repositioning or managing moisture and incontinence may require a lot of different steps, especially if you have a patient who's unconscious or a patient who's heavily overweight, that any one of these tasks becomes complex. Whereas, how can we simplify it? How can we take this from a complex realm to a simple realm? And colleagues and I, over the last few years, have tried to translate the understanding that nurses face in preventing infection and preventing pressure injury and falls and the like, from a series of complex tasks or complex dimensions into something more simplified. And we introduced this term as a way to describe the fundamental logjam of the situation, referred to as complexity bias. So next time you're talking to your CNO and they're asking, why are pressure injury rates so high? You might be able to explain it to them as, I think we have a complexity bias in our health system. That's defined as systems tending to overcomplicate the reduction of patient harm, and in a state of confusion, breaking down into many parts that address limited components of the greater problem. You see here, now there's a checklist for everything, right? Like I've shown you. And so if there's a checklist for everything, each one of those checklists was supposed to simplify the prevention of an individual problem. But now with many checklists, we just create a complex health system in another way. So how do we do this all at once? And how do we do this without creating unintended consequences that lead to other failures of the patient? I think the answer here is that we need to think differently. And there's a lot of great frameworks out there in order to consider improvement of quality at the patient level. There's this classic figure here called the inverted pyramid of quality improvement that was introduced by the Institute for Healthcare Improvement. And I use this in order to guide this principle that rather than having a complex system with many checklists, can we boil down patient safety and improved outcomes to a single checklist that achieves prevention of pressure injury and of CAUTI and of potentially DVT and falls and other types of infection? And the answer is potentially yes. When you look at the common risk factors of many of these hospital-acquired conditions that I've mentioned so far, there are, in fact, 3 domains of health that I do believe, and my colleagues believe that publish this together, could improve outcomes by managing them or by treating the risk factors. It's nutrition, it's mobility, it's moisture. If I manage nutrition, I obviously follow the pressure injury prevention guideline, but I do much for the patient in terms of giving them the ammunition in their body to fight off an infection. If I manage mobility, I'm not just addressing immobility that causes pressure injury prevention, but I'm managing falls, I'm managing DVT, I'm managing the need to catheterize or ventilate the patient, of course. And then finally, with moisture management, I'm managing pressure injury prevention, but I'm also managing the moist environment from which some strains like C. diff thrive in. And so it's not necessarily having to follow a checklist for each one of these conditions, but can we create a checklist that introduces nutritional management, mobility management, and moisture management to drive down the risk factors for all of these common hospital-acquired conditions at once? And so the answer is there is a checklist out there now that helps do this, and it's the Standardized Pressure Injury Prevention Protocol, or we like to call it SPIP. So colleagues and I on the National Pressure Injury Advisory Panel developed the SPIP checklist this past year as a way to address the risk factors of all these nutritional, moisture, and mobility issues. And it's centered around pressure injury prevention, but it's an attempt to address complexity bias and have positive consequences on not just improving pressure injury prevention, but improving the prevention of CAUTI and improving the prevention of DVT or falls or other types of infections. It has not yet been tested, but it's been content validated as consistent with the international guideline. And obviously, it's a one-page checklist, as you see here. You do not need to follow through 350 pages of a guideline. You simply need to check all the boxes here. Of course, not everything fits for every patient, but on average, checking these boxes every day for every patient puts you on a trajectory towards improving the prevention of pressure injuries. This SPIP checklist is free to download at the National Pressure Injury Advisory Panel. We published it as a brief report in the Journal of Advanced Nursing, and you can also download a free copy of the full paper from that journal. So invite you to check this out. And I want to dive into some of the core components of this checklist with you today, starting with dressings, because I always get a ton of dressing questions for some reasons. Maybe it's because I've done some research on dressing effectiveness and cost effectiveness. But of course, it's a question that still comes up. There are many manufacturers out there of dressings. There are many different types of dressings. And so can we accurately assess whether dressings play a key role here in pressure injury prevention? And to probably put out the first question quickly is, dressings do not replace the other steps in the guideline. It doesn't replace the other boxes that you need to check. It's a complement. And what we see here, as the language implies in the SPIP checklist, that by placing the silicone multi-layer foam dressing on high-risk areas like the sacrum, the heels, and the lower buttocks, that we might be able to improve the likelihood that a patient is discharged safely without harm. And that ties right back into what we need to accomplish here in addressing the complexity bias present in hospital-acquired condition prevention, that dressings overlap heavily with multiple components of this framework, that dressings represent moisture management because, of course, they absorb moisture well, and they can be managed with respect to mobility, that a patient that is immobilized that has a dressing on them, let's say on their sacrum, has an additional barrier to protect them from the friction, shearing, and pressure forces that are present on the skin while they're bedridden. And then obviously skin integrity, which is overlapping all of these different components of the Venn diagram, is key to the success. So I see that this one example technology is something that we could achieve a lot with together for the improvement of the patient's safety from pressure injury prevention. Now, this isn't news that dressings are a good component to a pressure injury prevention protocol. In fact, we see dating back to the international guideline that dressings have always been given positive strength of evidence to suggest it's something that you should do for the patient rather than not do for the patient. But I love to quote Joyce Black here, who wrote a really nice editorial for the Annals of Internal Medicine. Many of you may know Joyce Black. She's also a former and current president of the National Pressure Injury Advisory Panel. She came back to serve again as president starting last year. that there's still a dire need for good science in dressing prevention, in repositioning, in moisture and incontinence management. Across the board, the field has struggled to improve its strength of evidence. And so my interest here was to look at how we could understand the effectiveness of dressings, in particular in the real world, because obviously it's become a popular commodity in pressure injury prevention. And so in addition to the clinical trial evidence that already exists in small numbers of patients, could we do this work on a scale up? And so I set out to conduct some research on the real world effectiveness of dressings, as well as to better understand their value. And that work was published in this paper in the Journal of Wound Ostomy and Continence Nurses several years ago. I'll take you through it and hopefully give you a better sense of, based on large samples using real world evidence from a cohort of over 30 academic medical centers in the United States, we can have a high degree of statistical confidence that dressings work well as part of a pressure injury prevention protocol. How I went about doing this research in this paper was I started with a large data set. And so in the United States, there's a consortium of academic medical centers that work together through this group called Vizient. It's a cooperative of data that they all share with each other. It has the big hitter hospitals in the US like Johns Hopkins and Mayo Clinic and Stanford and Harvard and Penn, you name it. So we were able to identify a cohort of academic medical centers across a long period of time, 2010 to 2015, and identify patients specifically diagnosed with the hospital-acquired pressure injury rate defined by the AHRQ patient safety indicator. I combined that Vizient data with sales data from one of the dressing vendors because I needed their data in order to see how trends in dressing purchases were increasing as it correlates with rates of pressure injuries. And so I achieved the combination of those two data sets and then ran a regression analysis of the changes in pressure injury rates over time as the use of dressings increased, and also ran a cost effectiveness analysis alongside that study. So here's a look at just table one, which shows you the power of these, what we call real world data, that from a sample of 38 academic medical centers over 5 years, I was able to get over 1 million patient samples in this database. And what is interesting about trends in these data that I highlight here in the red circle at the bottom, pressure injury rates are going down and dressing adoption is skyrocketing. You see dressing adoption went up as a rate, it went up almost tenfold over a 5-year period. And pressure injury rates were cut by more than half. So it tells you that you don't need to be an econometrician or a statistician to know something positive is happening here. And in fact, when I look at these exact data on the next slide, you see that there is a trend in the downward rate of pressure injury associated with dressing adoption. So a very promising outlook for the use of dressings and pressure injuries. But that's not where I stopped. I went a step further, and this figure and the statistical results below tell a very important and accurate story when it comes to pressure injury prevention, is that there was a 30% risk reduction in pressure injuries in the real world when for each dressing that was introduced on patients. So that just means to say, like, given your choices, and you do have a choice, it's not a requirement to follow the guideline, it's perhaps at your clinical judgment. Should you use dressings as part of a pressure injury prevention protocol? You probably should, because we're seeing improvements in the real world. Now, you might notice 30% risk reduction is not the same risk reduction that we see in clinical trials. Going back to the early 2010s, Grindle et al., Santa Maria et al., Callows et al. All indicate that reductions of pressure injuries with dressings were more in the range of 70 to 80%. but that's in a clinical trial. That's in a controlled environment. This is real world evidence. This is happening as we see it, with regular variability in practice, different levels of training among the nursing staff, let's say, that would apply dressings to patients, among other things. And when you add all that up and control for those unobserved factors, you still get a 30% reduction between dressings and pressure injury outcomes. So I say that is positive news for us as a field and for the patient especially. Okay, so hopefully at this point, I've convinced you that there are core components of the SPIP checklist, like dressings, that individually hold muster when it comes to being implemented for the benefit of the patient. But in addition to clinical evidence, what is the value added of, let's say, dressings on a patient or following this SPIP checklist to improve not just pressure injury prevention, but potentially hospital-acquired condition prevention across the board? And when I say value, I think about this function. As an economist, I'm always looking at value in terms of quality increased relative to time and cost invested. And by quality, I mean some function of safety, efficacy, efficiency, effectiveness. So I've done a lot of work over the course of my career on, of course, value assessment using economic methods, and specifically, what is the value in pressure injury prevention? And I try to break down value into several key parameters here. There is cost effectiveness analysis and cost benefit analysis. That's usually helpful for us as clinical folks, clinically minded researchers to think about. There is budget impact analysis, which I think is an important statistic to communicate to a payer, to a decision maker, someone who manages a lot of lives, because they're always thinking, I have a risk pool, I have an insurance pot that I have to manage, and many people are paying into it, let's say through taxes or insurance premiums, and a few people need to use that pool in order to treat their own individual conditions. And then lastly, there's return on investment. And I hold that one for last because it's probably the one that many of you on the line need to remember the most, that your CFO, your CEO at your health system, they have a limited pot of money. Let's say they have $1 million. And if they're asked by 10 people for $500,000, they're just not going to be able to get it all around. So you come to them with a proposition that I want to improve pressure injury prevention at the hospital, and it's going to cost a few $100,000. Let's say it costs $150,000 to just buy a truckload of dressings for the next several months. And they say, well, what's your ROI? Do I get my money back, or am I just sinking money into this? And the answer is you'll get a return on investment, and I'll show you what that looks like. All of these economic statistics are based on foundations and medical cost effectiveness analysis. Using the figure on the left, we always like to try and get into that bottom right quadrant where we're reducing costs on a health system and we're improving health-related quality of life or qualities for the patient. Of course, that's the ideal scenario. Most of the time, we're spending more to get more. And that's that upper right quadrant where there's different, let's say, scales of value, from very good value, I'm not spending much and I'm getting a lot of improvement in health-related quality of life, to I'm spending a lot, I'm getting improvement in quality of life, but it's questionable whether that is cost-effective or worth it at this time. Of course, we never want to spend more money and lose on clinical benefits to the patient. And so the figure on the left is sort of illustrated in words on the table on the right. And the way we do this analysis is to perform incremental cost effectiveness analysis, or thinking of this term, the ICER, which is simply differences in cost over differences in effect. You probably thought that you were not going to get equations in today's lecture, but you bring an economist to Wounds Canada, I'm going to give you some equations to go home with. In any case, distilling that theoretical foundation of medical cost effectiveness analysis, let's look at the value added of pressure injury prevention and other hospital-acquired conditions. What we see here is that, for instance, a paper colleagues and I published on risk assessment of pressure injuries, the question became, do I always need to follow up with a patient if I know they're low risk? And what we found actually is that consistently following up with every patient every day using a standardized risk assessment tool like the Braden scale is the most cost-effective, efficient option. It's best value for money. And in fact, trying to cut corners thinking, well, this patient's only extremely low risk. Their Braden score is over 19. I don't need to follow up with them tomorrow. That's not good value for the patient, because in the chance that they do change in their risk trajectory because of some subtle difference, like they're no longer mobile or they've been placed on a catheter, for instance, that all those subtle differences dramatically change their risk trajectory, and therefore the best value for money in terms of improving health-related quality of life at a higher cost is doing prevention risk assessment on all patients every day, as the guideline recommends. We also see running cost effectiveness analysis like on these prophylactic dressings, that there's good clinical evidence combined with economic evidence to support that these dressings are extremely cost effective from a number of different societal standpoints. In this paper that was published in International Wound Journal, Santa Maria and Chen and I ran analysis of prophylactic dressings in nursing homes in both the United States and in Australia. So you could argue that Canada falls somewhere in the middle there as far as economics of what your willingness to pay is for this type of a prevention strategy. And in both societies, it was highly cost effective to implement a pressure injury prevention protocol that includes dressings. And these numbers would be consistent with most technology assessment bodies in Canada and in the UK and a lot of other Western countries that think like both of us in terms of healthcare. Lastly, a more recent publication that I led with the American Hospital Association shows that there are efficient ways of addressing pressure injury, and then there are less efficient ways of preventing pressure injury. And again, tying that to dressings, that dressings represent a simple, elegant, efficient solution to reduce pressure injury rates. There are other types of technologies too coming along that I think improve health outcomes with respect to dressings. Repositioning systems like LEAF is one of them that we hear about today. And perhaps combining two technologies like a dressing and a repositioning system lead to better cost-effective patient outcomes. But there is a rate of limiting return. And that's where the SPIP checklist, I emphasize, you don't have to do everything all at once for every patient, but there are necessary steps that need to be covered. That spending unlimited amounts of money to prevent pressure injuries in every patient doesn't always lead to better, healthier outcomes. And at the end of the day, we need to conserve resources for other routine tasks as well. So perhaps starting with a simple strategy and scaling up over time until you think that you've reached your goal or reached your threshold for spending is probably a wise move to make in the process of developing a quality improvement strategy. So in summary, when it comes to some of these technologies like dressings for pressure injury prevention, of course, it's recommended in the international guideline. We re-upped that recommendation recently as NPIP in the SPIP checklist. I think it's tackling complexity bias head on. The clinical effectiveness of dressings are established based on research using real-world evidence and economic evidence. And this means that there's a lot you can do with dressings. You can be early in intervening with these types of barriers before the skin breaks to allow for a reversal of damage, or of course to protect against the friction, shearing, and pressure forces. And they can be targeted to certain anatomies where patients are predisposed to a higher risk of pressure injury. If a patient can't get out of bed much and they have their legs up, putting them on their heels and sacrum makes sense. If they're tending to lay on their side or are prone position because of a particular device or like respirator that they're using at the time, then placing it on the chin and on the cheekbones and forehead, for instance, and on the chest and shoulders, that's where it makes a lot of sense. So Be targeted, be analytical in how you apply these health technologies, and I think you'll see better outcomes as a whole. We're all close with, for my presentation today, of course, is understanding the impact of prophylactic dressings on pressure injury prevention is only the first step. Clinicians need to understand proper and meaningful use of these dressings, of course. Like, it does no good to inefficiently apply them all over the place and put them on the walls in your break room and stuff. Be considerate of who's an at-risk patient that could really benefit from this. And I think targeted intervention of the highest risk patients, bundling this technology with other technologies that seem to fit the practice and culture of your health system, and teaching nurses how to conduct wound care assessment and implementing these technologies to trigger preventive practices is the right method. So it's a lot of things that all need to happen all at once. And by creating this well-oiled environment, I think you can see better outcomes. I just want to mention in closing that the National Pressure Injury Advisory Panel, of course, as I mentioned before, which the Canadian Pressure Injury Advisory Panel is very closely aligned with, is establishing several mission committees on standards to try and guarantee the consistent I'll say the consistency of these health technologies, especially dressings and support surfaces. There are two standards initiatives now, one in dressings and support surfaces, to ensure that the technologies that are claimed by any manufacturer are consistent. That if you buy a dressing with one brand, it's similar to a dressing of another brand if their product has been reviewed by NPIAP. This is, of course, to protect competitive markets for companies that innovate and manufacture good quality products at a fair market value, ensure that new market entrants don't undercut the existing price or quality of an existing product, and overcome the concern that not all dressings are created equal, so that you can have confidence that whoever is your supplier, whoever you contract with, that you're getting a good quality product. It's not done yet. For instance, the Prophylactic Dressing Standards Initiative continues to be a work in progress, but it's something NPIP is doing in order to make the field more consistent and ensure that you can improve patient safety, one patient, one dressing, one bed, one repositioning system at a time. So these are my references in case you're interested, and I thank you for your time today, and Anna would welcome any questions that people have.
Thank you so much, Dr. Padula. We are now going to begin our question and answer session. And as a reminder, you can still submit your questions through the Q&A box. So we have our first question here, Dr. Padula. How many people make an effective team for preventing pressure injury in a hostile setting?
Yeah, that's a great question. Thanks for that one. Colleagues and I did a study a couple years ago showing that actually using the same data from that Vizient database, that the highest performing hospitals in the United States had between 5 and 7 board certified woundostomy and continence nurses per 1,000 beds. Again, that's 5 to 7 board certified woundostomy continence nurses per 1,000 hospital beds. And so that helps you, right? Because maybe you're working in a 500 bed facility. Telling your chief nurse officer that based on the evidence, I need 2 to 3 board certified wound care nurses in this hospital gets you critical bandwidth to be able to implement a pressure injury prevention protocol. And what does that really mean? It's not feasible for 2 or 3 board certified nurses to run up and down the floors of a hospital and reposition a patient side to side every 2 to 4 hours, do it 500 times. What is practical, though, is that, of course, we know nurses who are board certified in specialty of wound care are the nurse educators. They're the ones who study the evidence. They're the ones who analyze the technology. They're the ones who think locally about what is the best fit for our culture. And they're capable of educating the staff nurses that are at the bedside to be able to perform most of the routine tasks in pressure injury prevention. And so you could imagine that in a 500-bed hospital, having 3 board-certified WOCNs full-time, you've got one very focused on education, one perhaps doing rounds and consulting at the bedside, ensuring that practices are being carried out consistently, and then maybe a third who's dealing with the most complex patients across the ICUs and surgical units where special care and attention may be required, or perhaps that rare case of a pressure injury. So those numbers seem to be good. And that's another published paper in the literature that, of course, it was in Journal of Patient Safety. And so you're not asking for 2 to 3 nurses per 500 beds or 5 to 7 nurses per 1,000 beds because you need it. You're asking for it because that's what the evidence tells you need.
Okay, great. We have another question here from the Q&A. So healthcare systems are looking at any way to reduce the care costs, given inflation and cost of supplies, while payments have remained the same. We are often faced with evaluating different supplies that are cheaper. Is there tools for clinicians to support certain brands of dressings versus other brands?
I'm not familiar with tools that specifically differentiate the different brands of dressings. I think what I do is obviously point you to the evidence that I've introduced here, that there are economic evaluations of dressings on the whole, that dressings can be a cost-effective technology. I appreciate what you're saying, that perhaps one dressing may cost $3, another dressing may cost $5 or more or less, I don't know. But in any case, certainly you need to start with isolating the dressings that you're considering down to the ones that have an evidence base. There's a lot of health technology out there that doesn't have an evidence base. And that is not evidence-based technology. That's just technology that someone's claiming to be similar to something else. So depending on who comes in your door and says, I want to sell you something, the first question should be, show me your evidence. And if they show you their evidence, then that's a conversation starter for value, because if something is clinically effective and perhaps has an associated economic study done with it, then you understand what the value of that technology is better. However, if they say, oh, we don't have any evidence of our own, but I can refer you to this evidence published by this other brand, this other manufacturer, that's a red flag right there. Most manufacturers in this space don't have evidence associated with their individual technology. They're relying on the evidence of other brands. And that means that they have nothing to guarantee clinically in the value and clinical effectiveness of their product.
Okay, thank you. We have one more question here. Any data on pressure injuries, long-term care, and low nurse patient ratios with increasing use of non-regulated staff?
It's a very specific question.
Mm-hmm.
I'm not sure that I have a knowledge of that information. You know, the key word that I'm hearing is non-regulated staff. Obviously, there are certain tasks in the pressure injury prevention guideline that are so easy a caveman could do it, right? Like repositioning a patient side to side is something that many different types of people can do. You don't have to have an RN or an MD or a PT diploma in order to conduct those tasks, but they do need to be trained by somebody on how to do them who's qualified, like a certified wound ostomy continence nurse. And so I'd say it depends on your budget. It depends on your bandwidth. That of course you need to train individuals on how to do certain routine tasks, and if they're consistent in doing them, then you have nothing to worry about. It's of course it's tough to do research on non-regulated individuals simply because they're not well documented in clinical charts and other types of data that someone like myself could analyze.
For sure, thank you. Yes, so we have a lot of people here in the Q&A. Just thank you for this amazing presentation. we don't have any further questions. Thanks again for your time, Dr. Padula, for your engaging talk, and thank you everyone for attending today's webinar, Understanding the Value of Guideline-Based Practice for Preventing Pressure Injuries. If you have any other questions, please get in touch with Wounds Canada at info@woundscanada.ca. Once you leave today's webinar, you'll receive a survey on this presentation, and we really appreciate your feedback. You also have an opportunity to sign up for future updates from Mölnlycke. And a follow-up email will be sent to you in a few days from Wounds Canada with a link to review the recording of today's webinar. On behalf of Dr. Padula, Mölnlycke, and Wounds Canada, thank you for joining us today, and have a lovely evening, everyone.
Thank you.
Thank you.